Our session today on advanced MedDRA coding. My name is Dr. Samina Qureshi, and I'm an international medical officer with the MSSO. I'm based here in the United States on the Eastern Coast in the state of Maryland, and I'm going to be your instructor today. Now, joining me today, as you may have heard a few minutes ago, will be my MSSO colleague, Sarah Clark. She's going to help facilitate today's webinar. Now, as Sarah mentioned, in order to be interactive, we will be using the Poll EV software so that you can participate in the coding exercises. Now, the instructions to join this Poll EV are in the chat section of the GoToMeeting control panel. Now, throughout the presentation, at various points, I am going to prompt you to log into Poll EV, and at that time, you can participate in the questions. As well, I'm also going to share the QR code for those of you who are going to use your smartphone to log in. Now, one additional point I do want to mention is that the Q&A portion that we have set aside towards the end of the presentation is for answering questions about the various principles we discussed today. And it's not intended for general coding questions or any other topic. The session itself is scheduled for 2 hours, but depending on the volume and Q&A, we may finish a little bit earlier. I'm also going to demonstrate various functions in the MedDRA web-based browser today. I'm a little partial to that one. And for that, if you want to follow along and you've forgotten your own user ID or password, we have provided a temporary training ID and password for you to use. This is going to also be available in the chat section of the GoToMeeting control panel. Okay, so with that, let's get started. Okay, so before we begin, for some of you who may not have, ever logged into or joined any of our other training sessions, I just want to provide a brief historical background for MedDRA. MedDRA is an ICH initiative, and the ICH is the International Council for Harmonization. It was adopted, the development of MedDRA was begun around the mid-1990s. Now, as you know, MedDRA is a living, breathing, and ever-evolving terminology. Therefore, the ICH appointed the MSSO, or the MedDRA Maintenance and Support Services Organization, various tasks and functions. One of them is to further develop the terminology, and this is usually done primarily through user feedback. As well, the MSSO is tasked with developing and delivering training, such as the one you have today, and as well to administer MedDRA licenses. Now, all of these MSSO activities are overseen by the ICH's MedDRA Management Committee. And the MedDRA Management Committee is composed of various industry and regulatory bodies, with the WHO acting as an observer. Okay, and of course, if some of you have attended our previous presentations, you know that we must go through this disclaimer slide. The first bullet talks about the fact that MedDRA is owned by the ICH. All of the material presented today is also copyrighted material and owned by the ICH. Now, one good thing is that aside from the logos, all of the material presented today can be used by you in your organization with the appropriate acknowledgements. Now, in case you modify or change any of the material in any way, you must make a disclaimer and specifically acknowledge those changes, and the fact that those changes are in no way supported by the ICH. And the second bullet is a bit of legal lingo, so I'll have to read it as such. The presentation is provided as is, without warranty of any kind. In no event shall the ICH or the authors of the original presentation be liable for any claim, damages, or other liability arising from the use of the presentation. And the third bullet, thankfully, is not relevant to us because it talks about third-party material, and today's presentation has no third-party material. Okay, so let's actually start into the presentation itself. Now that those formal slides are completed, let's talk about what we're going to discuss in today's course. So first and foremost, we're going to discuss the various principles outlined in the MedDRA Term Selection Points to Consider document. And we did go over this document in somewhat if you've taken the previous MedDRA Coding Basics session. We're going to discuss MedDRA concept descriptions, and we're going to show you many examples of how to properly code some of the more advanced principles that you encounter. As well, we're going to demonstrate and use the web-based browser. And of course, as I mentioned before, we're going to be using the Poll Everywhere platform to test how well you understand each of these coding principles as we go along and discuss them. And of course, towards the end, I'm going to summarize everything and present some wisdom or MedDRA coding pearls for you. And we'll conclude with a dedicated question and answer session towards the end. And of course, that's going to be around the things that we've discussed today. You are free to ask questions, and I would be pleased to answer them. Okay, so let's get started. Now, this is a little bit of a direction on how to participate in Poll EV. First of all, whenever it's time, I'll prompt you, and actually let's go ahead and do that so that we can, I have one question I'll have for you just to test we can all successfully log in. Open anything that you're using, whether it's your laptop, your tablet, or your cell phone, and in the type in pollev.com. Once you do that, you enter as the username right here in red, SAMINAQURESH185, and then you just click join. You don't have to enter anything else. And the third screen will be, you just click on skip. And for those of you who are using your smartphone, just use this. It'll quickly take you to Poll EV on your cell phones or your smart cameras. Use this Poll EV. I'll leave it up for a second. And again, then username is SAMINAQURESH185. And then you hit skip on the next screen. And that should take you to the Poll EV. Let me log in so we can all test the first Poll EV question. Here's the Poll EV question. Have you already attended a MedDRA Coding Basics webinar? So let me see based on your answers if people are successfully able to log in. Okay, so it looks like people are able to log in because I have 89% of you answering yes. So a majority of you are familiar with our webinars and have attended the MedDRA Coding Basics webinar, which is recommended to be taken before today's session. 14% of you never attended a session, and those of you, 2% are saying no, but you are very experienced coders. Okay, so this is the ideal mix and the preferred mix of people that we like for this particular session. So very happy to see that a lot of you can log in. Are there any questions at this point in the chat section? If there are, let's address them now.
We do not.
Wonderful, excellent. So that means it was pretty easy to join. Okay, so let's go back to our presentation. Okay, so as I said, the first thing we're going to discuss, and actually all of the examples and the various coding principles that I'll demonstrate today are summarized and memorialized and addressed in our MedDRA term selection points to consider document. So this document, which you can access, and I'll show you as well later how to access that from our website as well as from the MedDRA web-based browser. It is a document that is used as a framework for you to develop your own internal coding guidelines as well as to perform coding functions. Okay, and this is released every year in March with the 0.0 MedDRA release, and it basically is aligned with the complex version release of MedDRA, and the complex version release of MedDRA has changes in all levels of the MedDRA hierarchy. It provides term selection advice for both industry as well as regulators, so everyone is aligned and on the same page when they address coding. And of course, the primary purpose of this document is to promote accurate and consistent term selection so that everyone is coding uniformly. Okay, and now the PTC for each particular concept or each particular scenario provides a preferred option as well as an alternate option on how to capture terms. You can choose whichever option you need and you want that aligns with the nature of your data. So either the preferred option will suit you better or the alternate option. So you have both choices. Now this MedDRA term selection points to consider document was developed by a working group within the ICH Management Committee, and as I mentioned before, it's updated annually every March, aligned with the complex release of MedDRA. There are complete versions available in the languages of English, Japanese, Chinese, Korean, Spanish, and Russian. And for all the other languages in which MedDRA is available, it's available in the condensed version. And as I mentioned, it is available and accessible from our MedDRA website, as well as the JMO website, which is the Japanese Maintenance Organization, and they are our sister organization and maintain the Japanese version of MedDRA. And let me just show you at this point how to access this document. When you go on our website, this is the MedDRA.org website. This is our website. You can go to the documentation under the How to Use tab, and within the drop down, you click on Support Documentation, and there it takes you to all of our whole suite of points to consider documents, among which is the MedDRA term selection points to consider document. Okay. As well, I'll show you how to get to the MedDRA web-based browser. You can get to it from our website. Up on the top, you see this acronym WBB. I click on that and I come to the web-based browser. It's already pre-populated with my particular MedDRA ID and username. And once you're in the MedDRA web-based browser, you see at the very top all of these blue panels, and here is also another option, another way to access the MedDRA points to consider document. There's a tab called MedDRA documentation. I click on that, and again, it takes me to the points right here in the website where the support documentation is available. Okay, so two ways to access this document. Okay, and again, as I mentioned before, the objective is to be able to code consistently both industry as well as regulators. Okay, and here's just the sort of the index on all the topics covered by the term selection points to consider document. As you can see, there's a whole variety of terms, a whole variety of concepts and scenarios and topics it addresses: diagnoses, provisional diagnoses, how you address that, how do you address death, age versus event specificity, and so forth. Very comprehensive list. Here's a continuation of the things and the topics that the term selection points to consider document addresses. As you will note, it addresses various concepts of different types of medication errors. And just to let you know, we have a whole webinar dedicated on medication errors to go if you want to go into further detail and various scenarios within medication errors concepts. Okay, now here we're going to now start basically on general principles. One of the primary general principles of MedDRA coding is to always, your aim should be, and your utmost significance is to select a low-level term or an LLT that most accurately matches or reflects whatever is being reported in your case report or the reported verbatim. Here we have an example. For example, in my verbatim, if I have abscess on face, which is being reported to me. Okay, when we think of abscess, you know, if this is the only, when you think of an abscess can be anywhere, right? On your skin, in the brain, in the lung, on the face. Now, for me, my report says abscess on face. So if I were to select the LLT abscess, while not totally incorrect, it's not very specific, because as I mentioned before, an abscess can be anywhere anatomically. So you want to code as precise as possible to what is being reported. So the term, the LLT term, which would be the most suitable and most correct and most specific, would be LLT facial abscess. So just the take-home message here is pick the LLT that most accurately reflects the reported verbatim, and in this scenario, the most specific LLT would be facial abscess. Okay, and again, the thing is, keep in mind, only select current LLTs. Some LLTs in the MedDRA dictionary have been marked non-current, and those are just there and visible to you for legacy purposes, so that you can tell at some point in time this particular LLT did exist, but for our coding purposes, you cannot choose, or you should not choose, an LLT that is marked non-current. And that is shown in the browser. That will show in the browser with a red box around it. Okay, another aspect to consider when you're coding, when do you select more than one term? Okay, you can select more than one LLT to represent the reported information if by doing so that enables you to most accurately and specifically capture what is being reported. Okay, let's look at here. For example, if I am given a report or my verbatim term says metastatic gingival cancer, if I just select, I can think, well, what should I select as an LT? Gingival cancer or just metastatic carcinoma? Either of these LLTs alone would not be adequate to fully represent what is being reported to you, right? So if I were to code gingival cancer, yes, I would get the gingival cancer part, adequately, but I would not capture the fact that it's metastatic, right? So the best answer or the best way to capture this reported verbatim would be to select two LLTs. One where it's anatomically located, gingival cancer, and the LLT metastatic carcinoma. Okay? So you don't simply pick two LLTs because you don't want to be redundant, right? You want to be adequately representing what is being reported. Now, things to keep in mind when you pick two LLTs to capture a term. It's a good thing because you're not losing the specificity. The other thing is, though, when you pick two LLTs, that may lead to redundant counts. Therefore, it's very important, as we're writing right here, to document your procedures, right? So somewhere in your coding guidelines, it should state that in some scenarios, in some cases, in order to most clearly and accurately and specifically capture the reported verbatim, it may be necessary to use more than one LLT. So that should be somehow memorialized in your internal coding conventions. Okay, another thing we want to keep in mind is whenever you pick a low-level term or an LLT, make sure, especially if you're a beginner, to check in the MedDRA hierarchy how that is linked. For example, check for your particular chosen LLT which PT it is under, which HLT that PT is linked to, which HLGT and SOC is that particular term linked to, in order to make sure that the term that you're picking is accurately reflecting what you want to convey. Okay, so for example, just as an example to illustrate this point, for example, you want to code a report of low energy, but you don't see that particular exact match LLT in the dictionary. So you decide to choose LLT worn out because it kind of conveys that concept. And in order to ensure or make sure that this particular term is correct, you see that this LLT is linked to the PT fatigue, and therefore you feel satisfied that this is the correct LLT, and you are in fact conveying the right message or the right term. Okay, so here's another thing I'd like to bring your attention to: concept descriptions. What are concept descriptions and where are they found? So I'll illustrate that for you. Concept descriptions are descriptions of how a concept is to be used or interpreted for the purposes of MedDRA. It's not a definition per se, so it's incorrect to say there are definitions of terms. They are merely descriptions of the way we use that term within MedDRA. Okay, and it's intended to make sure everyone has the same understanding of how that concept is used, and we want consistent usage of that particular term in MedDRA. And of course, as you know, globally MedDRA is used, and therefore it's very important to have concept descriptions so everyone understands, even despite the various global language translations, of how we want to use that particular term. And these are accessible in MSSO MedDRA browsers. And I'll show you again when we go to the web-based browser where those are. So here, I'm already logged into the MedDRA web-based browser. Once you're in the browser, at the left-hand side at the very top, there's a blue panel that says MedDRA Concept Descriptions. When I click on that, there's an alphabetical listing of all of the various concepts which we have concept descriptions. And the very first thing is abuse. So for the purposes of MedDRA, abuse is understood to be as such. And then if you go down the list, we have various concepts. We also address addiction. For the purposes of MedDRA, how do we want you to interpret the concept of addiction and so forth? Okay, so these are MedDRA concept descriptions. Okay, so any questions thus far before we move forward further?
No, not at this time.
Wonderful. Now what we're going to do, it's time to pay attention because we're going to go through the various scenarios and various challenges that people have in coding one by one. Okay, so now we actually begin the things that are listed in the points to consider document. Okay, the very first thing, let's talk about diagnoses and provisional diagnoses. How do you address when in your coding reports or when you start to code, when a particular diagnosis is given, right? So the very first scenario, how do you address and how do you code when a single diagnosis is given, but there's no signs and symptoms, right? So it's also important to clear what is the difference between a sign and symptoms. So for our discussion purposes, a symptom is something that is, subjective, something that the patient complains about. For example, the patient will say, I'm dizzy, I'm nauseous, is something that the patient experiences. Whereas a sign is something more objective. It's a finding, which the patient might not even know they have. For example, the patient might have a cardiac murmur. They may have a very fast pulse rate, or their blood pressure may be very high, right? These are signs that the patient may not be aware of, and they're very objective, whereas symptoms are something that they experience and they'll report. Okay, so now that we're sure what a sign symptom is, what's the difference? If there's a single diagnosis reported to you but does not report any signs and symptoms, it's very easy. You only code the diagnosis, right? So for example, it's reported the person had a myocardial infarction. Simple enough, you just code myocardial infarction. Okay, versus a provisional diagnosis. If you're given a provisional diagnosis without any signs and symptoms, how do you code that? The answer is, well, you have nothing else, so you just code whatever is the given provisional diagnosis. Now, some of you, just to be clear, what is the difference between a diagnosis and a provisional diagnosis? A diagnosis is something that's definite, right? The healthcare provider or the patient has been told, this is your diagnosis, this is the disease or issue that you have. It's definitive. Whereas a provisional diagnosis is something that's not been quite confirmed yet. And the way to sort of know that something is being reported as a provisional diagnosis, you'll probably have the words suspected, possible, rule out, right? So they're not sure, but they think the person has this particular disease or condition. Okay? It hasn't, the diagnosis per se has not been confirmed yet, therefore it's called a provisional diagnosis. And here in the example, you see that we know that the myocardial infarction is a provisional diagnosis because the word possible is in there. It could be myocardial infarction. And the way to code that is obviously that's the only information you have is to select the term myocardial infarction. LLT myocardial infarction. Okay, so here the second scenario is what if you have a diagnosis, but in this case you do have a diagnosis as well as signs and symptoms. The preferred option written in our PTC document is to code the diagnosis only. Okay, so for example, I'm given a diagnosis of anaphylactic reaction, and then I'm also given a list of all the signs that go along with anaphylactic reaction. Anaphylactic reaction with rash, dyspnea, hypotension, and laryngospasm. So the preferred option tells us you only need to capture the diagnosis. So in this case, I would only code anaphylactic reaction. In the second scenario, what if you have a single provisional diagnosis also with signs and symptoms? The preferred option here is a little different. Here they say the preferred option is to code the provisional diagnosis and all of the reported signs and symptoms. So if my reported verbatim said possible myocardial infarction, so that's a provisional diagnosis, with chest pain, dyspnea, diaphoresis. So then I would capture the provisional diagnosis as well as all of the signs and symptoms. So I'm going to code myocardial infarction, chest pain, dyspnea, and diaphoresis. And this is based on our PTC document. Okay, so let's go on to additional scenarios. Here, for the same thing, single diagnosis with signs and symptoms. We know that the preferred option for a definitive diagnosis was just to capture the diagnosis, but you could, as it says, the alternate option is you could also, if you want, code the diagnosis as well as the signs and symptoms. Similarly, for a single provisional diagnosis with signs and symptoms, the alternate is to capture the signs and symptoms only. Okay, so here's a bit of a difference. Here, if it's a provisional diagnosis, the alternate option is to just capture the signs and symptoms. Because the reasoning is since it's provisional, meaning it's not been confirmed, it might change, but it's very important to capture the signs and symptoms. So in this scenario, the alternate option would be just to code the signs and symptoms, chest pain, dyspnea, and diaphoresis. So these charts and these instructions and these alternate and preferred options are memorialized and they are written in the PTC document for you to access. Okay, here, always include signs and symptoms not associated with the diagnosis. So you know that there are always, with every diagnosis, there are always these gold standard signs and symptoms that you always find in a patient with that particular diagnosis. On the other hand, there are some signs and symptoms that are going to be reported that may not be associated with that particular diagnosis. For example, it's reported to us that myocardial infarction, chest pain, dyspnea, diaphoresis, ECG changes, and jaundice. Okay? So our preferred option, as you remember in the PTC, was when you have a diagnosis, the preferred option is not to code the gold standard signs and symptoms associated with that diagnosis. So in this case, we won't do that. So we'll only capture the myocardial infarction, right? Because that's the definitive diagnosis. But we're also going to capture jaundice because this is not one of the gold standard typical signs and symptoms of myocardial infarction. So we're going to code both myocardial infarction as well as jaundice. Now, I hope I have not stumped anyone so far. Are there any questions?
There are. The first one was, would it make sense to have an LLT or a PT metastatic gingival cancer?
Excellent question. So the thing is yes, it is possible to have that LLT, but it would overpopulate MedDRA if we were to have every anatomical location metastatic term, right? Therefore, we have just a wild card term, metastatic carcinoma, and then you have various anatomic locations, and then you can do double coding, right? Two codes. So it's possible, but it would be impossible to have that metastatic option with every anatomical location. Okay, any other question?
Yep, we just had one more. When I receive an adverse events with only signs and symptoms, vomits, oh, then another one just popped in, sorry. When I receive an adverse events with only signs and symptoms, vomits, shall I report 2 different reports to VigiFlow?
I didn't quite understand the question, but if you have a report with just no diagnosis, just a list of signs and symptoms, you should absolutely capture each sign and symptom with a LLT. Because there's no diagnosis, it's just a list of symptoms, right? So you just capture all the signs and symptoms reported, each one individually.
Perfect.
Any other question?
Yep, if a verbatim has rule out, it does not sound right to code this term, right?
So when you say rule out, when a report says suspected, let's say suspected myocardial infarction or probable myocardial infarction or rule out myocardial infarction, you would code that because that is a provisional diagnosis. The doctor is saying, I think it's this, but let's take tests to say it's not that. Otherwise, we want to make sure it's not this, and I need confirmatory tests to say so or to confirm that. So it would be treated as a provisional diagnosis and you would code that.
And then finally, what is the function of the alternative way?
So based on at the beginning, we said there are always two options to address a particular scenario in the PTC, a preferred option and an alternate option. Due to the nature and the variety of types of nature of data that organizations have, sometimes the alternate option might suit an organization better than the preferred option. So we have both listed. Okay, so let's move on. And then if there are any questions, we'll address those towards the end. We'll have time for that. So let's move on for the, make sure that we get through the presentation itself. Okay. All right, so what about when you try to obtain more specific, when you have conflicting or ambiguous information, right? It's sort of conflicting with one another, both things. Then you try to get more information or you get a clarity or a follow-up query. So here, for example, you have reported hyperkalemia with a serum potassium of 1.6 milliequivalents per liter, right? And the LLT, so hyperkalemia by definition means an increased, someone has too much potassium, right? So they have that diagnosis, but they have a lab result that is kind of conflicting because the normal, roughly the range of potassium is 3.5 to 5.5. So how can they be diagnosed with hyper, which means more, with a conflicting lab value of a low, right? In that case, when you have conflicting information, so what does one do? So then you can select the abnormal option for that particular finding. In this case, serum potassium abnormal, right? Serum potassium abnormal covers both of the reported concepts, right? The fact that it's reported as a low as well as the hyper. So that we know something wrong, it's some abnormal, right? But we can't commit to say increased or decreased because both are reported here. So the way to address that is to say abnormal. What about when it says GU pain, right? Sometimes there are acronyms in there. If you don't have other information, contextual information elsewhere in the report to clarify this, GU on its own, just reported as such, could either be genitourinary or gastric ulcer, right? And as I said, if there's no additional information available in the report, then the best thing to do is only report that part which is certain, the fact that there's pain, right? So we're not going to say which area of anatomical system of the body there's pain, but we're just going to say, okay, there's pain. I'm not going to commit whether it's genitourinary or gastric ulcer if I don't have any other information or clue in the report. And I can't, I'm unable to query. Okay. Now let's continue. What about vague information? How do you address information that you're not really sure what they mean, right? First of all, the primary goal should be to either query or try to get more information. Okay, so for example, it says turn green, all right? I would choose the LLT. The best LLT to choose would be unevaluable event, right? Because standing on its own, turned green could be the person turned green, or was it, the pills turned green after over the expiry date or whatever reason it could be. Was it a product that turned green? Was it a thing that turned green, or was it the patient himself that turned green? So I can't make that assumption, right? We shouldn't assume or add any information that's not reported. Therefore, we would code unevaluable event. In our second scenario, we have patient had a medical problem of unclear type. At least here we know that the patient, something's going on with the person, the patient. So in this case, instead of saying unevaluable event, which is very broad, we can say ill-defined disorder because we know it's in a person, right? So at least this is, somewhat saying that in the person, there's something that's ill-defined. He has some sort of disorder. Whereas in the first scenario, we don't even know if it's a product or if it's a person. Okay, now if we keep going, sometimes it's difficult to know which particular code to do. So if I'm reporting, if I in my report have the verbatim clinical complication of IUD, right? I could pick this term in MedDRA, we have in the browser IUD complication. which goes to the PT of complication associated with device, right? Because IUD can stand for intrauterine device. Or I could pick intrauterine death, because IUD, I could interpret that meaning as meaning intrauterine death. And this particular LLT links to PT fetal death, right? Or I could pick unevaluable event. And the best choice would be to choose unevaluable event, right? Because as you can see, as I explained, there are two totally different things depending on the LLT I choose. Either I'm just saying something, happened with a device, or I could even assuming that it's something to do with the fetus. So if I'm not sure what IUD stands for and I don't have context in the report and I'm unable to get additional information, the safest bet would be to choose unevaluable event. Again, we choose this very broad term because we don't know, are they talking about a product like a device, or are they talking about a person, right? So unevaluable event would be the best term LLT to choose to code this. In the second scenario, we have reported, so this is what's being reported in my report: hypoglycemia, and in parentheses it says blood glucose equals 200 milligrams per DL. Now, hypoglycemia means low, right? It means a low blood sugar. Hypoglycemia, low glucose. But my lab report in parentheses conflicts with this term because a normal blood glucose, mg per DL, is usually around 70 to 99. And this in itself is high. So how can I report a low term with a high lab value given in parentheses? So what would I do in this scenario? The best thing to do, as I said in previous slides, would not to commit to say hypoglycemia, because this part is sort of opposite of this. I can't commit and just say blood glucose increase, because the hypoglycemia is leading to the other direction. So the safest bet, and the way that the PTC document tells you when you have conflicting information, is to use blood glucose abnormal. Okay, so that's the take-home message here. Okay, and those are the correct results. Okay, what about medical condition versus an investigation result, right? So if we're reported hypoglycemia, it's very important to know the difference between the two. Hypoglycemia, you would pick the exact match, hypoglycemia. And this particular term links to the SOC, metabolism and nutrition disorders, because it's type of like a diagnosis, right? Whereas a decreased glucose is merely a lab result, right? Decreased glucose would be captured with the LLT, glucose decreased. And this specific LLT links to the SOC investigation. So it's very important, especially if you're beginning and new to MedDRA, to look at the links in the hierarchy of the term that you choose to make sure it's exactly what you're trying to convey. Are you reporting an LLT that's a disorder type of term, right? A diagnosis type of term, or are you reporting something that's just a lab result, right? So the take-home message here is to look at the links of where it goes in the MedDRA hierarchy to make sure the concept is correct. Okay, here, an unambiguous investigation result. Unambiguous means it's clear, right? If you're reported a glucose 40 with units mg per DL, you can very confidently say this means it's a low glucose, because the normal range of glucose is 75 to 100 milligrams per DL. And this is below 75, so we know that based on universal standards, it's low. So glucose is clearly below the reference range, so we feel comfortable and confident by picking this LLT. Now, if you have ambiguous results, ambiguous means uncertain, unclear. If I'm reported his glucose was 40, in this case, here we had units. Here we don't have units, we just have a number. And that makes a difference, because we don't know if they're reporting by the British standards of millimole per, because in Europe sometimes their units are different, millimole per liter. And if it were millimole per liter, the normal in that unit is about 4 to 8. And in that case, that would be way high, right? Versus if it's reporting in milligrams per DL, which we typically do in the US, then that's low. As I said before, in milligrams per DL, a normal range glucose is 75 to 100. So units make a difference. And since here we don't want to assume which units they're saying, the best bet would be to choose the LLT glucose abnormal, right? When you're not certain if it's low or high, abnormal is the best bet. Okay, and of course, this is assuming that you can't get clarification and you can't query, you can't get additional information. Okay, now here we're going with in the scenario of investigation results that are consistent with a diagnosis. So if they say elevated potassium, right, they give you that, and then they give you lab results of potassium 7.0 millimoles per liter and hyperkalemia. Okay, so here a normal potassium typically in millimole per liter is 3.5 to 5.5. So that's correct. You know, that is, it's accurate to say elevated because the normal is 3.5 to 5.5 with those units. And the diagnosis of hyperkalemia. So my labs align with the diagnosis, so I can very confidently choose the LLT hyperkalemia. And I don't have to choose LLT potassium increase because that's a sign of hyperkalemia, right? So this is the correct choice when everything, the results are consistent with the diagnosis. Okay, here in the second scenario, we have a group of investigation result terms. How do we address that? So for us here in this example, it's been reported increased alkaline phosphatase, as well as increased SGPT, increased SGOT, and elevated LDH, right? They have a whole list of lab results and you know whether and they're all elevated or increased. How would we code that? Well, very simple. You take each one individually, find the best exact exact match LLT. So we do have exact match SGPT increased. For increased SGPT, we have exact match SGOT increased for this increased SGOT and so forth. So we selected all four individual terms. You could not, even if you're medical sense and your physicians out there in the audience, you're saying, well, obviously his liver function tests are abnormal, you know, with all that information. Our medical hat needs to go off and we cannot assume, right? Because these result findings may be many other disorders as well. So when lab results are reported, do an exact match with the most closest LLT with that lab result and do not choose an LLT that could be a possible diagnosis. We cannot diagnose. Okay. Are any questions before we move forward?
Yes, we have a few. In the case of hyperkalemia, should we also code the units of potassium in the lab test, like the amount of potassium?
No, because here it says elevated potassium, right? And then they give you potassium 7.0, which is also elevated. Because I mentioned to you when you look at the charts, the reference range 3.5 to 5.5 is normal, and 7 is obviously high. And this is correct. It aligns with elevated potassium, and that is aligns with the diagnosis of hyperkalemia. And our PTC document set, when you have a diagnosis, and signs and symptoms, lab results, the preferred option is just code the diagnosis. But the alternate option says you can code signs and symptoms and labs. So if you wanted to, and you want to adopt the alternate option in your coding guidelines, you could say potassium increased as your LLT. Yes. So the question is, if you wanted to, you could say potassium increased as well, although it's not necessary, but you could if you wanted to.
Do we need the confirmation that the signs are linked to diagnosis to not code them?
If it's reported in that in the same case report, you can assume that it's linked with that patient and he has a diagnosis of X and he has all the signs and symptoms and labs associated with that diagnosis or whatever it may be, then you don't need to capture them individually. You can assume they're part of that diagnosis.
It should be queried when there is conflict information in the verbatim. It should be a suitable LLT only if the query is not an option, right?
Correct. Correct. When that option to query is not available and you don't have clarity and you don't get an answer or clarification, that's when you use that as a last resort.
And then finally, would it be correct to assume the units according to the country where the report is from?
We usually don't like to make assumptions because, this is global audience. MedDRA is used globally. But if you, in the context of your organization or in the context of where your reports are coming from, and you're sure they're from the US and most likely they're using that particular country's units, you can make that based on your medical judgment.
Perfect. Thank you.
Okay, so here, excellent questions. I really appreciate your questions. It means that you are actually, thinking and processing this. So very, very good. Well done. Okay, so what terms to collect? Testing showed, again, here's a scenario, increased serum creatinine and BUN with increased BUN creatinine ratio, right? From among these choices, which one would you choose? So you have increased serum creatinine, BUN increased, blood urea nitrogen creatinine ratio increased, and renal function tests abnormal. So let me just tell you, as we said before, you would take a group of lab results, right, or findings, and code them one by one. Increased serum creatinine, so the first choice is correct. The second one says increased serum creatinine and BUN, so basically increased BUN, so you would say BUN increase. This is a correct choice as well. So first one, second one, and third one is correct as well because it says increased BUN creatinine ratio. So excuse me. Okay, so the fourth one, renal function test NOS abnormal, would be incorrect because here we're assuming, right, that there's more than these three in renal function tests. So when we choose this would be incorrect. For the next example, patient had features of aldosterone excess. We have these three choices: aldosterone increased, aldosteronism, and blood aldosterone abnormal. The best choice in this, I'll give a second for everyone to just think about it, and then I'll tell you the right answer. And this is discussion. We're going to have lots and lots of practice coding examples as we move forward in the session. The best choice in this is giving you, we can make the assumption when it says aldosterone excess, the best choice among these three is aldosteronism, because that's basically what aldosteronism is. It's aldosterone excess. So the best choice would be this, and not just aldosterone increase, that's like sort of like a lab value, or blood aldosterone abnormal. Okay. Okay, there's the right answers. Okay, now we're going to address combination terms. And this is a good area. Some people often have questions in this area. When it's reported to you, arrhythmia, okay, some people say, okay, I got it. There's an LLT arrhythmia. I'm going to choose that LLT. But you look at the complete sentence. It says arrhythmia due to atrial fibrillation. So it's going further and explaining to you that the arrhythmia is because of the atrial fibrillation, or this is the type of arrhythmia, because atrial fibrillation is a type of arrhythmia. The best code would be the specific arrhythmia, right? Atrial fibrillation. In the second example, you have hepatic function disorder, and in parentheses, you have acute hepatitis, so which is very specific. It's a type of liver function disorder. So instead of just coding the very broad term hepatic function disorder, which doesn't really tell you much because there are lots and lots of types of hepatic disorders, Why not choose what's given in parentheses, which is very specific, a type of hepatic function disorder, which is acute hepatitis. Therefore, the correct choice would be hepatitis acute. Okay, now here we come to existing LLTs in MedDRA that are combination terms. When it's reported to you retinopathy due to diabetes, you wouldn't choose LLT diabetes alone and then another LLT retinopathy. Your primary goal would be to look for a term perhaps that has both of these concepts in one. And lo and behold, there's a very specific LLT called diabetic retinopathy, which captures this, right? If you're brand new in MedDRA, you would say, okay, let me pick retinopathy LLT. Let me separately pick another LLT diabetes. But the more seasoned coder or the more industrious coder would look through MedDRA and look for a term perhaps that's available that has both. So diabetic retinopathy is the correct answer. How about rash with itching? Again, if you were new to MedDRA, you would say, well, I'll pick a LLT. I know there's LLT rash, and there's separately just a plain LLT itching. You're correct, but why not pick an LLT that has both concepts, itchy rash? This one term captures what's being described or reported. Similarly, a breast cancer, yes, there's an LLT, plain old breast cancer, but when the report specifies what type it is, a HER2 positive, the aim or the goal should be to pick the most precise LLT that matches the given verbatim, and that in this case is HER2 positive breast cancer. Now, admittedly, there are not always LLTs available that capture, the combination term, right? So in that case, you would have to pick two LLTs, but you do a thorough search and look through MedDRA very well. And if there is a term like in this case, then you pick that term that combines both concepts if it's available. Okay. Now, if splitting provides more clinical information, select more than one term. In all cases of combinations term, in combination terms, obviously apply medical judgment. And of course, diarrhea and vomiting are two separate concepts, and therefore you would pick two LLT. Wrist fracture due to fall. Again, these are two concepts because there's no one LLT that captures both. So you would have to pick wrist fracture separately and an LLT for fall. Here, BRAF positive malignant melanoma. Again, you have an LLT for BRAF gene mutation, and then you have a LLT for malignant melanoma. Okay. Now, in all of these scenarios, it's important to capture with two LLT because important concepts are being reported in the report. Okay. Now, what about here? We have retinal disease from HIV with near total blindness. So here, at the very experienced coder realizes there's lots of information here, right? Retinal disease from HIV. So it's not just a plain retinal disease, it's because of his HIV. And as a result, he has near total blindness, and they go on to tell you it's right and left. So what are the good terms that we could use? There's retinal damage, there's retinal disorder, there's HIV disease, because I do see HIV in here. There's the term blindness, there's the term HIV retinopathy, and blindness both eyes. These are the correct terms. And why are these the correct terms? Because the retinopathy, pathy basically means disease, right? Disorder. His retinal disease from HIV, and I have a very good LLT in this case, HIV retinopathy, that captures that instead of separately capturing it, retinal disease and separately capturing HIV. And then the rest of it, near total blindness, right and left. I would pick the LLT blindness that goes on to say both eyes. Now, if here, I could have picked blindness, right? But that's not complete. I have a term that says both eyes, and my verbatim is telling me it's both eyes, right? And although HIV disease is correct, retinal disease or damage disorder are correct, Why not pick the HIV retinopathy that captures both? And therefore, the last two were the correct answers. Okay. Now let's go on to this. Medication errors. So for the purposes of MedDRA coded data, medication errors are defined as any unintentional, right? They're not done on purpose, they're unintentional and preventable event that may lead or cause inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. So for the purposes of MedDRA, this is how medication errors are defined. Okay, now, of course, as I said before, you can see these MedDRA concept descriptions both from the website, website, or you can access them in the MedDRA web-based browser. And we discuss medication errors in a whole lot of detail, a whole lot of depth in the MedDRA Points to Consider companion document, which is a separate document in section 3, because medication errors are very well defined and they go very granular in that document as to the types of medication errors. And the way to look, if you're not too familiar with medication error terms, is within the MedDRA browser, go under the HLGT medication errors and other product use errors and issues. Then you'll see all the HLT, all the PTs having to do with medication errors if you're not familiar. Now here we're just going to go briefly because, as I said, the points to consider companion document talks about these in detail, as well as if you're very interested and you encounter medication errors a lot in your clinical work, we have dedicated webinars dealing with medication errors, a whole session and webinar on very intricacies and granular detail on how to address those. Here we're going to just touch upon them. Now, if a medication error is reported with clinical consequences, select terms for the error as well as the consequences. So let's go into this. It was reported to us that the patient was administered a wrong drug and experienced hypotension, right? So it's a type of medication error, right? He was administered the wrong drug. So the LLT to capture would be wrong drug administered. But you wouldn't stop there, right? What happened because of that? Well, because the wrong drug was administered, he experienced hypotension. So you must capture the result as well, or the consequence. In the second example, because of similar sounding drug names, right? There's lots of drugs out there, as you know, that sound alike, although they have totally different indication, totally different class of drug. The wrong drug was dispensed, right? Because they sounded alike, the wrong drug was dispensed. As a result, the patient took the wrong drug and experienced a rash. So a lot of things are going on here. First of all, what happened in the whole chain of events? The wrong drug was dispensed. So we have the LLG, wrong drug dispensed. And since it was dispensed, the patient took it. So the wrong drug was administered. And he got a rash, right? So we write rash, as well as the originating error. This all happened because the drugs sounded alike, right? It sounded like another drug. So we have an LLT that says drug names sound alike. So you see, if you're not familiar with MedDRA, you'll be amazed at the granularity it has. And we do have an LLG, drug names sound alike. So the originating error, and in this case, so you should be familiar with this terminology. Originating error means what caused all of this, the wrong drug being dispensed, right? And what happened because of that, right? What happened because of that is that he got a rash and he took it. So we captured wrong drug administered, we captured rash. As well as the whole thing was done because of the contributing factor, which was the fact that the name sounded alike other drugs, right? And we captured that as well. So this is a very complex topic of medication errors. So I highly recommend, if you want to learn more, or if you face or encounter these scenarios very frequently, to listen to our medication errors webinars. Here we'll continue a bit more. For example, in your report, if you're given insulin preparation was given using the wrong syringe, resulting in the administration of an overdose. The patient developed hypoglycemia. So a lot is going on here as well. The insulin preparation used the wrong syringe, and because of that, resulted in administration of an overdose. So the wrong syringe was used, the person was administered an overdose, and there was a consequence. He got hypoglycemia. So here, the correct LLTs to use: drug administered in wrong device, right? As well as accidental overdose. It was by accident. They didn't give it to him on purpose. And the reason we can use overdose is because it's specifically stated. And then, of course, the consequence. Okay? So all these are various aspects of capturing medication errors. You get the contributory error, you get the originating error, and you get the consequence as well. You have to capture all three. Now, how about medication errors where there is no clinical consequence, right? Okay, so here we're looking at reporting medication errors without clinical consequences. There's no adverse event or adverse reaction. So all you do is you just pick the medication error that happened. So let's look at this in more detail. If it's reported to you that an intramuscular formulation medication was given IV intravenously instead of intramuscularly, but the patient didn't have any adverse event. So we can't make it up, right? So the preferred option would be to say intramuscular formulation administered by other route. Okay, so that's the preferred option. Although in the alternate option, if you want to, in your nature of your data requires, you may say that LLT as well as no adverse effect. Depends on your coding guidelines and what your internal coding guidelines prefer. Okay, now it's important to record the occurrence or the potential occurrence of a medication error. And you do that by selecting the term closest to the described error. Okay, so for example, let's take our example for this scenario. Pharmacist notices that the names of two drugs look similar and is concerned that this may result in someone getting the wrong drug. Okay, so here we remember we said sometimes it's important within the context of medication errors to capture potential occurrence. So in this case, the pharmacist noticed something, right? That the drug's name looked alike. So we have a very specific LLT for that drug name look alike. As well, he's concerned that there's a potential for error. So you capture potential for medication error, wrong drug. So as I said before, unless you're familiar with all of these LLTs, you'll be amazed how granular we do have terms. This example is a potential medication error. The LLT drug name lookalike is a contributing factor, right? And the LLT potential for medication error indicates that there's a potential for this specific type of medication error. So I would advise to get familiar with all of the LLTs within the medication errors, HLGT. Okay, any questions thus far?
Yes, we have a few. We have one that says, if we have dehydration due to diarrhea, we need to code both diarrhea and the consequence dehydration, as in different terms.
Correct. Very good. Yes, you would capture both, because it's possible that someone has diarrhea, but they not to the extent that they get dehydration. But if it's reported they have diarrhea, and this kind of tells you that it's so frequent or so severe that it resulted in a consequence of they got dehydrated. So yes, it's important to capture both. Good job.
Perfect. If a diagnosis is first reported, such as a drug allergy, and then it was later clarified with a non-standard symptom, such as constipation, would it be correct to keep the drug allergy coded along with constipation, or to replace the drug allergy coded with constipation?
It's really hard to answer these coding questions. As I said, I'd like to address questions that have to do with the examples at hand, but I'll just generally say that not knowing, although I don't know the full scenario, I would capture each individual event, both.
Okay. Someone was referring to slide 35, and they say, in the studies I code, the study requires a single medical diagnosis or a sign or symptom. What are your recommendations for coding those events on slide 35?
So on slide 35, I assume this is the one they're talking about.
Mhm.
Is this the right one?
I'm assuming yes. I'll
Okay.
see if they pop in, but otherwise, yes.
Yeah, so I think what they're asking, if I'm not mistaken, is if there's a diagnosis as well as signs and symptoms of that diagnosis. You can, like I said before, there's a preferred option to code only the diagnosis and not the associated gold standard signs and symptoms of that diagnosis. But alternatively, if your organization wants to, the alternate option is to code both the diagnosis and all of the signs and symptoms. So, you can refer to your points to consider document and look at the particular scenarios and the preferred and alternate options. Okay, so we'll move forward and then we'll save other questions for the period at the end.
Perfect.
Okay, okay, we did this one, we did this one. Okay, so here we're addressing other concepts. As you know, we're going step by step and addressing the various scenarios that the PTC addresses as well. Here we're looking at how to address overdose, toxicity, and poisoning. And it's very important at the outset to say that if either three of these concepts, they have to be explicitly reported to select them as an LLT, right? So it says, for example, in my report, if it says stomach upset from the study drug overdose, I would definitely code the stomach upset. And because it specifically states overdose, then I can say overdose, right? I can't assume if they say, oh, he took too much of something. And if they say he took too much of drug X and got stomach upset, I can't code overdose, even though it says took too much, because it's not explicitly reported. I can't infer. Okay, here, overdose without a clinical consequence. Patient received an overdose of medicine without any adverse effects. It's explicitly saying overdose, therefore I can code overdose. And whether I code the fact that nothing happened with no adverse effect is an option. It's an alternate option, but not the preferred option. You can do it if your organization desires to do so. Okay. How do we address death and other patient outcomes? Death, disability, and hospitalization are considered outcomes and not usually coded as AEs, right? Because usually on report forms, you have a separate outcomes field where you capture three of these concepts, right? So typically you don't capture these as AEs or ARs. If one of these outcomes is the only reported information, if that's all that's being reported, patient died, then you would capture it, okay? If a death term in MedDRA adds important clinical information, then you code it along, and we'll give you an example. Patient experienced a rash and had sudden cardiac death, right? So we would code rash, and in this scenario, we would code, because it's giving you information, it's a type of death, right? It's telling you, okay, it was due to sudden cardiac death. So in this case, you would be correct to code both. Okay? How about drug interactions? You can't assume a drug interaction happened again unless it's explicitly reported. Term includes reactions between drugs, includes biologic products and other drugs, foods, devices, and alcohol. Now, if a reporter states an interaction, you select the most specific LLT for that interaction term and any subsequent medical events or adverse events. So here, it's reported to us. Patient drank cranberry juice, which interacted. So they're explicitly saying it interacted with the anticoagulant drug and it caused an INR increase. So what happened? The cranberry juice interacted and they explicitly told us with the drug. So I can safely code with food interaction as well as INR increased. Again, the take-home message here is if the reporter does not specifically state an interaction, you can't code that. Just select terms for the reported event. INR increased, right? Just like death, and toxicity and poisoning. If it's not explicitly stated, do not code an interaction term. Okay, how do you address suicide and self-harm? Coding of suicide attempts, and there's various suicide terms. There's suicide attempt, there's completed suicide, and various self-harm terms should be accurate and consistent. Do not assume that if someone has an overdose, even if it's intentional, it's a suicide attempt, right? So for example, someone says, the girl was depressed, she took an overdose of pills, that's it. Don't also code, she attempted suicide, right? Don't assume she's going to, or that it's going to be a suicide attempt because she took a lot, 59 pills. You only code that which has been provided and given to you, especially suicide. If it's not written, you don't code it. Don't infer it. If a self-harm report does not mention suicide or suicide attempt, only code self-injury term. If a suicide attempt is fatal, select a term that reflects the outcome instead of the attempt. So what they mean is, for example, if it says in the report, suicide was attempted and the person died, right? So obviously you know that suicide unfortunately happened and the person died, then you would say completed suicide and not attempt. The suicide attempt resulted in death, right? So you don't code suicide attempt because they're telling you that it resulted in death. Instead, capture the completed suicide. And then in addition, report death as an outcome. So this would be the code, and this in the outcome field, you would put death. Okay, how about here? Death from cerebral hemorrhage. What would you do in this case? Take a little time to think about it. Okay, would you code sudden death? Would you code death? Would you code cerebral hemorrhage? Would you code brain death? Remember we said choose the most appropriate adverse event that's reported, and death, unless it's a specific type of death, always gets coded in the outcome field. So in this case, death would be recorded in the outcome field. We would only code cerebral hemorrhage. Okay, so this example was to see if you had understood the previous take-home messages on how to address suicide, death, overdose, and whatnot. How about in this case? Patient was found dead. We can choose death from natural causes, just death, died in sleep, or found dead. What would be the best choice? So just think about it, and then I'll discuss what I chose. The best choice would be found dead. Because this is the only thing, right? There's nothing else reported. There's no cerebral hemorrhage, myocardial infarction, no other adverse event. In case nothing, remember we said in case nothing else is reported except death, then you would code it. Found dead, right? Okay, so what about this one? After taking an antihistamine along with her prescription proton pump inhibitor, a 53-year-old woman developed vertigo. So this is very interesting how you all are going to address this. I had addressed this point in my previous slides. So after taking an antihistamine along with her prescription proton pump inhibitor, 53-year-old woman developed vertigo. What would you choose? Drug interaction, vertigo subjective, or just plain old drug interaction or vertigo? Okay. The correct answer for some of you, it would be a surprise, is vertigo. Since it does not, a lot of you may say, well, I would do drug interaction because she took an antihistamine. Well, nowhere in the report does it say interaction, right? And our points to consider document says for interactions, unless it's explicitly stated, you do not code interaction. Okay, so for some of you, do please review the points to consider document around this aspect. Because after taking an antihistamine along with a prescription proton pump inhibitor, maybe those are the two medicines that, she's supposed to take. It doesn't say anywhere there was an interaction, so I would not code interaction. Okay, so let's get ready for some poll questions. I want everyone to log into your poll. If you're using a smartphone, please go here, use this QR code, and log into Poll EV. Okay, I hope everyone's logged in. Let's get started. What about this one? Let me see, what my poll is. Let me go into the poll as well. Okay, we already did this if you are MedDRA coding basics. Our second question is, okay, deliberately took an overdose. This is my verbatim, deliberately took an overdose. What would be my correct choice? Okay. So a lot of people who are thinking, double thinking, remember, let me just give you a hint. The best exact match LLT to the reported verbatim is what? Best match. Okay, so the best answer, correct answer is deliberate overdose because it's the closest matching to the reported verbatim, which says deliberately took an overdose. Now, the first choice is correct. Absolutely, it's not incorrect. But the reason deliberate overdose is correct is because it closely matches whatever is being reported. And again, for the 1%, we cannot assume it was a suicide attempt. Remember I said when you take an overdose, you can't assume it's unless it's stated in the verbatim that she attempted suicide. Okay, good. Let's go to the, let me go to my slide. Deliberate overdose was the correct choice. Okay, so I keep staying in the poll, but I just want, before I go to the next question, I just want to go over. When you're looking at the various verbatims, always consider what's being reported, right? Especially if you're a new coder, think, is this a diagnosis or is it a sign or symptom? Then you would go through all the various rules that I told you. Is what is being reported is a test result? Is it a medication error? Is it a device thing? So always in your mind, look at what is being reported. Consider what type of term is it. Okay, and that's going to help you sort of go towards the correct SOC and make sure you're addressing and choosing the most appropriate LLT. Okay, so let's go back to our poll. And our second question will be, okay, which LLT would you choose? Man with decreased fertility. Man with decreased fertility. Remember, exact match, that's a secret. That's the clue. What is the best match? Okay, I really like the people are excellent. 93% of my people have the correct choice. Fertility decreased male. Okay, why would we not choose infertility? Let's address that. We wouldn't choose infertility because that means he's absolutely infertile. It's totally, he has been declared infertile. Whereas this guy is somewhat fertile, but it's just decreased, right? So infertility male would be the wrong diagnosis, right? He's not completely infertile, he's just decreased. And the fertility decreased is correct, but I would choose the more specific one where the sex of the patient is given. Man with decreased fertility. So 95% of you absolutely did the right choice. Fertility decreased male. It's decreased and it's in a male. And it most closely matches the reported verbatim. Okay? And of course, if fertility decreased is totally different reasons, different etiology, physiology, if it's a male versus a female. And when I choose fertility decreased, it doesn't really go, give me full information versus male. Okay, so let's go to the next example. Became colorblind in adolescence. Let me activate that. Remember, closest match, became colorblind in adolescence. Okay, so 3 and okay, good. I wanna. This is a very minute difference, but let's see. Okay, so the first choice, color blindness, is correct. Blindness, color, but the additional information in adolescence tells me color blindness. Let me just illustrate this point. If I go in the browser and I choose color blindness, right? This is just to show you color blindness, right? If I choose that, for some of you who chose that, and I look, remember I said when you choose a term, if you're new, you should drill down and look at the hierarchy of the term that you chose. If I choose this term, it goes to primary SOC, and I know it's primary SOC because there's a blue box around the SOC. It goes to congenital. That means a congenital disorder is something the person is born with, right? Whereas my my verbatim is saying he got it in adolescence when he was in a, like in a teenage years, when he was an adolescent. So he wasn't born with it, he acquired it, right? Now the choice is between these two good terms. I want to choose the exact match. I mean, this is a very minor point, but color is spelled in American English, and the last choice, the color is spelled in American English, and therefore that's the correct choice. But 3 and 4 are absolutely correct choices. Just this is British English spelling of color, and this is American English spelling. And the reason we chose these two examples is to drive home the point to try to get the most exact match with the reported verbatim. So good job. Excellent job. Okay, so let's go to the next poll. Turned very greasy. Okay, let's see what you all would choose. Okay, turned very greasy. Okay, so let's see what people are doing. Ill-defined disorder, we had that example in the slides before. Skin greasy, unavailable reaction, and I am very happy that the majority of my attendees, 88%, said unvaluable event. And let me tell you why the others are wrong. Very minute differences, but let me tell you. The first one, ill-defined disorder, we would not say because this assumes that it's a person, right? When I say the verbatim turned very greasy, I'm not sure if it's a person or if it's a tablet that turned greasy, a device that turned greasy, like it's possible. What exactly turned greasy? Could be a thing or a person. Therefore, the ill-defined disorder assumes it's a person, so I can't use that. And obviously, this is totally wrong because it doesn't say skin anywhere. That's what you would think, though. The first thing that would pop in your mind is the skin turned greasy, but it's not nowhere in the verbatim, so I can't assume that. And as far as unevaluable event and unevaluable reaction, the unevaluable reaction infers between two things, and we don't know that, right? So the event is the best choice. Something happened. This is more broader than reaction, right? So something happened, an event happened, and we don't know, we can't evaluate it because it's very broad. So the best choice is this unevaluable event. Good job. Let's go to the next question. Patient reported medical problem. Okay, what would we do in this one? Here we know that the patient reported a medical problem. What would it be? Okay, we had a similar example in our slides before. And I'm very happy to see that the majority of my attendees are doing the correct answer, which is ill-defined disorder. Again, we know it's a person, right? That's why I can say it's a medical problem is a disorder, right? So ill-defined disorder is the best thing. Now, why wouldn't it be adverse event? This term is too vague, right? There's not much information. No information of the type. Is it in a person or a product? Adverse event could be used in both, right? But we do know it's a person. So I would go to something a bit more precise than very broad as adverse event. Now, unavailable event and unavailable reaction, we do know it's a person, right? So this is the best one for that. This would be maybe because, you know, you didn't know it was a person or a device or a product. These two would be used then. This is the best one because it's a person and it's some sort of problem or a disorder. Now you can read up on these as well in the points to consider document if you're having difficulty fine-tuning which one to use. Okay, so let's go to our next one. The two-year-old accidentally took his mother's medication. Which one would this be? We know it's accidental. I'm going to give you that hint. Okay. Okay, so the closest exact match, remember your aim is to do the exact match with what is being reported. Okay, and what did he take? For those of you who are wavering in between, he took a medication, right? Okay, so the correct answer is, like the majority of my attendees, accidental drug intake by child, because we know it's a drug. For those of you who used choice one, accidental product intake by child, product is a bit broad. It's not incorrect. It's technically correct, but since I know it was a medication or a drug, accidental drug intake is the correct best choice. Accidental exposure to product by child is incorrect because exposure sort of infers that it could be skin or eye, right? But here he took the medication. So it's not an exposure, it's a drug intake by child. And the last one is incorrect because it says unintended, whereas in this one it's accidental. It's more precise. Unintended is a little broader versus accidental, and we know it's accidental, so we would use accidental drug intake by child. So number 3 is the best choice. Okay, let's go to our next one. How about this one? Infection after surgery. Okay, this is a little tricky too. We can't assume anything, right? It just says infection after surgery. Does it tell us where it was? Okay, so since a majority of you, 96% of you have the correct answer, it's after surgery, so post-operative is very precise, and it's an infection. For those of you who chose post-op wound infection or surgical wound infection, we're assuming it's a wound. We don't know that. The verbatim doesn't say there was a wound. So we can't assume it was a wound. Most likely it was, but we can't assume that. Okay, maybe he got a throat infection after surgery, right? Who knows? Maybe his calf got infected, who knows? So post-operative infection is the most precise based on what was reported in the verbatim, okay? So let's move on to our next example in POE-EV. How about this one? Very short verbatim. Had MI. Okay, so this some of you who have the browser open, I would look for MI and see, or I would look up myocardial infarction, open up that PT and look at all the LLT under there. Would you be able to choose MI as in the third example here? Correct example, answer. Okay, so just for a second, I'm going to look up myocardial infarction in the browser, and I'm going to open it up. So you highlight it, right click, and go to browser. You highlight where it says primary SOC, When I open up on the left-hand side, the PT myocardial infarction, and I see all the LLT listed, I look for MI, and what happens? The LLT, MI, if you look, I can't use that LLT because it's non-current. How do I know it's non-current? Because it has a red box around the LLT. Anything with a red box around the LLT and a red LLT means it's a non-current LLT, and you should not use that for coding purposes. It's still listed in the MedDRA dictionary and in the browser just for hierarchical legacy purposes, so you know that at one time this LLT was available, but I can't use it now, right? So I can't use that, so that's out, so that can't be a choice. Okay, now can I assume that MI means myocardial infarction? Because MI on itself, unless the context of other things in the report lead me to believe, if it leads me to believe they're talking about myocardial infarction, then I can use the word myocardial, this code, myocardial infarction. But on its own, if I have no further information, no context in the report, this could mean mitral insufficiency. It could mean mental illness. It could mean mesenteric ischemia, right? So I can't assume that it necessarily means myocardial infarction. Therefore, the correct answer is what 81% of you had thought, unevaluable event. For the 10% that thought MI, that is a LLT, but it is non-current, and we can't assume that that's what it means. Okay, and it's non-current. Okay, so let's go to the next one. How about this one? Hypernatremia, which means, increased sodium, and in parentheses they have the lab of serum sodium 115 milliequivalents per liter, right? And as we know, if we look at a reference, a normal serum sodium is 135 to 145 milliequivalents per liter. So this value is low. And that contradicts with this hypernatremia, which means high. So this low lab value of what's expected in a normal serum sodium is conflicting with this hypernatremia. So what do we do? What would be the correct answer? We address this in our slides. Okay, excellent. So 96% of you have the right choice, which is serum sodium abnormal, because we had said when something is conflicting, you take the abnormal choice of that particular value. So perfect, good job. And the next one. She accidentally missed the morning dose. Okay, of these four, which is the best match? Missed dose, temporary interruption of therapy, intentional dose omission. Well, was it intentional? It says she accidentally missed the morning dose, or was it missed dose in error? Okay, so the correct choice, as 90% of my audience says, is missed dose in error, right? Because the in error captures the accidentally, and she missed it. Just missed dose is not wrong, but it doesn't fully take all of the information that's given to you. Because in this missed dose, we don't know, was it intentional? Did the doctor tell her to miss it? Did she miss it intentionally? Did she miss it accidentally? Right? So this one is the best choice. Temporary interruption of therapy, that can happen for some non-clinical and unintentional reasons. For example, maybe there's some financial reason because she didn't have enough money left, and so she had to temporarily interrupt her therapy. Or maybe she went, there's no supply, there's a supply chain issue, and she couldn't access her medicines. Now, for intentional dose, this is actually not in the verbatim. It's not intentional, it's accidental. So no one chose that, good, thankfully. So the correct choice is missed dose in error. Okay, how about the next one? It's a bit more verbose. The doctor, in this case, mistakenly prescribed the wrong drug. The pharmacist noticed the error and did not dispense the drug. Wow, this was one of the most difficult ones, and I'm surprised that majority of you got it right. Okay, so absolutely right when you say intercepted drug prescribing error, because we know that it was prescribed, it was wrong, right? So drug prescribing error, that part is correct. Additionally, after the pharmacist noticed the error, he didn't dispense it. So he stopped, he intercepted it. He didn't let it happen further, right? So the third choice, intercepted drug prescribing error, is absolutely correct. Okay, the wrong drug was not, this is incorrect because it wasn't dispensed, so that would be wrong. Medication error, yes, it's a medication error, but this is a very broad term. It doesn't really tell you anything. And our verbatim is telling you a lot of information. Intercepted drug dispensing error. This is incorrect because it was not a dispensing error, it was a prescribing error. So the third one adequately and completely captures what is being reported. So good job. So in this example, you learned that there are various prescribing errors, there are dispensing errors, there are administration errors had the person taken it. Okay, so let's go to our next example or coding exercise. Now this also brings home a very important concept that I mentioned in my slides earlier. Dose was taken was below the minimum recommended dose in the product label. So what happened? Dose taken was below the minimum recommended dose in the product label. Okay. Okay. So this is challenging. The challenge is between the first choice and the last choice, and that's very valid to be, you know, choosing both. The correct choice is number one, underdose, because when we, let me just show you, when we look in the MedDRA browser at the MedDRA concept descriptions and read under underdose, the concept description for underdose is underdose is the administration of less than the minimum recommended dose, right, in quantity and or concentration. So this concept description of underdose exactly matches that which is right here in our verbatim, below the minimum recommended dose in the label, right? So we have sufficiently described underdose so we can safely choose underdose. We wouldn't say incorrect dosage administered because, you know, we are valid when we choose the word underdose. So that's why the correct choice is underdose. Good job. So we're doing very well. I'm very pleased with the way you're doing. Okay. So the next one, this is very important. The take-home message here is to make sure you see the hierarchy of the term that you choose. Abused by her husband. Which code would be the correct? Physical abuse, battered wife, spousal abuse, or victim of spousal abuse? In this case, the hierarchy is important. Okay, and I'll tell you why each one of these is wrong or correct. I'll give you the reasoning for each one. Okay, surprisingly, this is the first example where the majority of my people are incorrect. The correct choice is 30% of you had victim of spousal abuse. And why is that? So if we take spousal abuse, okay, in my browser, I'm going to write spousal abuse. Remember I said when you pick a term, especially if you're new, you look at the hierarchy. The LLT spousal abuse, when we look at it and we drill down to look at the hierarchy, it goes to PT spousal abuse, which goes to criminal activity, and that goes to social circumstances. So when you choose the term spousal abuse, it implies that you are the perpetrator of that activity. So it's the person doing the abuse. He does the spousal abuse, or he or she does it, right? So in this case, we're talking about the person is the recipient of the abuse, right? So the correct term, victim of spousal abuse. So when we look at spousal abuse victim, which is the correct choice, victim of spousal abuse, it goes to the HLT crime victims, right? And not criminal activity as the previous term, right? So it's very important, as I mentioned before, when you choose a term and you're not sure, to look at the hierarchy so you correctly report that which is being reported. Okay? So the take-home message is it should be victim of spousal abuse and not spousal abuse, because this links to criminal activity. And it means the perpetrator, not the recipient of. Now, why would physical abuse be incorrect? Because we don't know if the abuse, when you say abused by her husband, the abuse may be verbal, right? Emotional, psychological, or physical. And so this is assuming it's physical. Battered wife, again, this assumes that it's physical abuse, right? That's the case of battered wife. So the correct choice is the last choice here, victim of. Okay? Any questions for that one? The previous one? Sarah?
Not for the previous one, no.
Okay. All right, so let's go on, and then we'll answer all the questions in the Q&A session. Okay, here we have this one. Let's activate it. The patient was treated with drug Z for rosacea, which is an off-label use of this medication. Unfortunately, she developed severe dizziness. And there's more than one you can choose. So there's more than one right answer, and we'll go over all the ones that can be correct. Okay, so I'll start. So the first one is correct, rosacea. She was, because it's an indication, the patient was treated with drug Z for rosacea. So we got the indication, which is an off-label use of this medication. Okay, unfortunately, she developed severe dizziness. Now, obviously, we would code the consequence, dizziness. So number 1 and number 2 are correct. Number 1 and number 4 are correct. Now, the choice is between 2 or 3. Do we choose 2 or do we use 3? The best choice is the second one, not the third. The second one tells you precisely, it's more precise than the third one. It tells you that it's off-label use based on the use of this medication, the indication of this medication. So the correct choices are number 1, number 2, and number 4, and not number 3, because it's not precise enough, given that you have this option as well. Okay. Now, in the term selection points to consider document where they talk about off-label use, when a medical condition or indication is reported with off-label use and an adverse event occurs, the preferred option in the points to consider document is to select PTs for the medical condition or in the indication of off-label use and the reported AE, right? So if you have a precise information in your reported narrative or verbatim of in which context the off-label use is, choose that one, the most precise one, if you have it in MedDRA. Okay, instead of just saying off-label use. If you have a more precise term as to what aspect was off-label, then you choose that. Okay, we're almost drawing towards the end. How about this one? A 27-year-old woman took a 2-week course of antibiotics during her pregnancy. She did not experience any side effects. What would be the preferred choice based on the PTC, the preferred option on how to address this particular verbatim? A 27-year-old woman took a 2-week course of antibiotics during her pregnancy. She didn't have any side effects. And the correct answer is the first one, based on the preferred option, maternal exposure during pregnancy. Okay. Now, if you also want to choose no adverse effect, you can do that. So both, either just the first LLT or both of these are correct. So this concludes the poll EV section of our presentation. So I will go back to the presentation, complete it, and then we'll go to the Q&A. Okay. Okay. Okay, so these are all the exercises that we had. Let's go. We did all the exercises, so no need to repeat those slides. Now we'll go on to our concluding slides. Okay. Okay, here let's sort of look at this one. Just a take-home message. Remember that MedDRA can be used to code more than adverse events. Remember some of the examples we also looked at the indication, right? So let's just break down this narrative just to take home that message. A 75-year-old male received drug X for rheumatoid arthritis. So in this case, he received the drug for this particular thing. So this is an indication, and MedDRA is widely used to capture indications as well. So after taking the drug for this particular indication, the man developed symptomatic aortic valve stenosis. So this is one of the adverse events, so you would capture that. The patient's medical history is significant for colon cancer and cigarette smoking. We would capture that as well because that's part of his medical history. He underwent an aortic valve replacement. So this is a procedural or surgical a thing that happened, an aortic valve replacement, and developed a sternal wound infection 3 days post-surgery. Now, this is something that happened post-operation, right? Post-operative wound infection. So we have MedDRA available to us to capture indications, adverse events, to code medical history, to capture various medical surgical procedures, as well as post-procedural complications or any events post-procedural. So this example was to show you that you can always be on the lookout on all the various things and various components in a particular verbatim that you can capture. Okay, so additional coding pearls that we gathered from today's presentation and various coding examples. I think the most important take-home message was try to get an LLT that most closely matches the actual words that have been reported to you. And be aware of MedDRA specificity, right? MedDRA's LLTs are very granular, so sometimes do some due diligence and look for the most granular, most closest LLT available to you. And sometimes look at various terms in the hierarchy. Remember, it's very important to look at the MedDRA hierarchy once you pick a term. Look at the other LLTs under there. Maybe you'll find something even closer. Look at what the PT is for that particular LLT. And check where the LLT lies in MedDRA. Remember that social circumstances, the abuser, and the spousal victim scenario. So it's very important to see where in the MedDRA hierarchy a particular term lies. And again, you can look at the SOCs if you're not familiar with MedDRA too much, and what is in a various SOC, or you can look at LLTs and drill down to which PT, HLT, and so forth. Now, if you're not familiar with a particular concept, you can always check various references just to get an idea. For example, you're not sure of a particular diagnosis and what are its gold standard signs and symptoms. Certainly check a medical reference to become confident and sure of what those signs and symptoms are. Okay, and of course you can utilize and leverage the various functionalities of your MedDRA browser, like the wildcard search with the percentage sign, right? And of course, become familiar with the MedDRA concept descriptions. So for the purposes of MedDRA, how various concepts are defined or described. And as I mentioned before, if you're interested in some particular aspect, like for example, if you want to know more about how to appropriately code various medication error terms, we have webinars, specific webinars wholly dedicated to that particular topic. And of course, if you find this too complex, you can always go to the MedDRA coding basics and work your way up to more and more complex trainings. So in effect, to summarize, we discussed various principles given in the MedDRA term selection points to consider document, where various preferred options, various alternate options, and of course you choose either one depending on the nature of your data characteristics in your organization. And of course, we looked at some MedDRA concept descriptions. We looked at some advanced principles. So today's examples were quite complex and they were considered advanced. You can use, we use the browser. Several times I showed you the MedDRA web-based browser, as well as Poll EV to see how you would answer the various questions. And of course, this is, you have a copy of the slides. You can always access our website, www.meddra.org. If you have any questions, this is the email to use, mssohelp@meddra.org. And of course, these are links to the various MedDRA browsers, the desktop and the web-based that I use today. And of course, some of you like the mobile browser. And this is links how to submit a change request for new terms, how to access our training schedule for upcoming face-to-face, web-based trainings, MedDRA support documentation. I showed you how to get to that from our website, www.meddra.org, as well as the MedDRA web-based browser, how to get to the various PTC documents. And now is time for our Q&A. So I'm open to any questions you may have having to do with the specific coding questions or examples I have in my discussion today. Okay.
Perfect. We're going to start with one of them that says the wrong drug administered implied wrong drug dispensed. So why would we also code wrong drug dispensed?
Okay, so it's a good idea to check the medication errors section of what dispensed is. Pharmacies and pharmacists usually dispense drugs. The prescription, there are various, in the various stages of how a drug reaches the patient. First of all, obviously it's manufactured. Then the physician will prescribe it. So there's various errors that can happen in the prescribing stage. Then there's various errors if it's prescribed correctly, but the error occurs when the pharmacist dispenses it. So there are stages in the dispensing phase where errors may occur. And then of course, once it's given to the patient may have various administration errors. He may take it wrong, or a healthcare provider may administer it incorrectly. So those are all different stages of where medication errors can occur.
Perfect. Someone is referencing slide 39, and they said,
Okay.
along with overdose, why no adverse effect not selected?
39. Let's go to 39. Okay, so here, overdose without clinical consequence. So the preferred option is to choose just overdose if they say there were no adverse consequences. But you can, if you want to, you can also choose no adverse effect. It depends on your preference. But the PTC preferred option in this, but alternate option is also to capture no adverse effect. So you may do so if you want.
Perfect. Then we're going to go down to, in our polling, it was number 6 out of the 17.
Okay.
And they said, why option is not there for adverse event NOS?
Patient reported a medical So this is slide 6, poll 6.
Yes.
Patient reported medical problem, right? And we had said the best option was ill-defined disorder. Can you repeat their question?
Yes, it says why option is not there for adverse event NOS.
Uh, because of the 4 choices, we discussed the ones that we have. We discussed of the 4 choices that I have as LLTs, these were the best. NOS means not otherwise specified. So that's not one of the LLTs listed.
And then we're going to skip to, in the polls, it was number 15. It was about the rosacea. I had a couple of questions that came in about that.
Number 15.
Yes. It says, why do we have to code the indication rosacea?
For this particular example, I wanted to show you all the things that MedDRA terminology can capture. Now, if you're in your particular organization, you don't capture indications because it's in a separate field or it's already done, and you only capture adverse events, in that case, you wouldn't. But just for the purposes of this exercise, I wanted to illustrate that MedDRA can capture indications, adverse events, medication errors, and so forth, as well as medical history. So that's why we captured rosacea in the example, that it is possible to capture indications.
Perfect. And then regarding the same question, it says, doesn't off-label use imply unapproved indication? So is it redundant?
No, off-label use may be for different things, not necessarily always for indication. Sometimes the indication is the same, right? It is used for the indication in the label, but it's used for the wrong dose, right? So there are different off-label scenarios and not necessarily always indication. Let me show you in the browser. Good question. Most often it is indication, but it can be, so as you can see, off-label can be for dosing amount, off-label can be for unapproved age group, right? Maybe it's for the indication of a particular cancer, but only in adults and not in young kids. So it was used off-label in the unapproved age group, but the right same indication. So there are various off-label scenarios. Okay.
Perfect. Someone else is just asking in general, is there any MedDRA webinar specific for concept descriptions?
There is not a specific webinar just for concept descriptions. Majority of webinars that discuss MedDRA do touch upon that, but there's nothing dedicated solely for that. What about the concept descriptions? Is there a question? When we access them, what I can tell you is you can access them from the web-based browser. They're listed in alphabetical order, and each of these things in the various alphabet, depending on what concept you're interested in, gives a brief description how, for within the context of the MedDRA terminology, how that particular concept is to be used. Okay.
Perfect. Where do you find the points to consider, and how can we register for more specific topics?
Okay, perfect question. So this is a view of the MedDRA web-based browser. At the very top, you see all these 4 panels. In the middle is the panel for MedDRA documentation. That when you click on that, that takes you to our website, and also this answers the other part. From our website, www.meddra.org, you go to the website, and under the How to Use box, there's a drop down, and again, that also gives you the support documentation. You click on that, and then at the very top in that support documentation tab, to make it easier for you, we have a tab, Points to Consider Documents, right? And we have a suite of points to consider documents. The one I discussed today is the MedDRA term selection points to consider. And then you have the MedDRA data retrieval and presentation points to consider. And you have the companion document, which lists section 3, talks a lot about medication errors. But the one we discussed today, if you click on that, the PTC comes up. And then you can go into that depending on what your question is, right? This is the most recent March 2024 release. And then it has an index table of contents depending on what your question is about. Let's say your question is about how to deal with death, right, and coding. You can go to that. For example, your question is about how to address various age event specific terms. So based on what your question is, you can read up upon that in that particular section and see what the points to consider document says. Okay, anything else?
How do we extract a list of PTs and LLTs belonging to a given SMQ in the MedDRA browser?
Okay, so you go to the MedDRA browser. So basically what I'll tell you for this webinar was for advanced MedDRA coding. There's a webinar specifically around SMQs, so the title is SMQs, but in your browser, and this is the web-based browser, in the browser view, you would change to SMQ view. Once you click that, you have the SMQs, right? All of the listed SMQs. And let's say I'm interested in SMQ renal failure. I can open that up and it will give you all a list of the narrow scope as well as the broad scope of that list of PTs. And of course, I would refer them to the SMQ webinar that goes into further detail on how to do that.
Fantastic. If we have a report where it says a patient had constipation and other adverse events, do we code constipation and adverse drug reaction?
No, what you would do is if you have the report and the report, has a whole list of things, adverse events that the patient encountered, you just capture constipation. It's what do you call it? It's assumed that that's one of the adverse events the patient had, along with any other if they're reported. You don't have to say, constipation and also code adverse event. No, you code adverse event when there's nothing in the report. For example, the report said patient took drug X, something happened. You don't know what happened, right? So then in that case, you can say adverse event or ill-defined disorder because it's a person. But you don't just code adverse event when you're given specific information as to what the adverse event is. Constipation, you only code constipation.
Can we assume, yes, can we assume the units if the values differ greatly between them? An example, degrees Celsius versus Fahrenheit.
You cannot assume units. I would not assume units. In that case, if, for example, in the many examples we gave you, glucose 40, right? There's no units. You would say glucose abnormal. You would use the abnormal LLT if there are no units given for that particular finding.
And then in the case of lab tests, the reference values are different in various laboratories and countries. What should we use as a reference?
So typically, I mean, yes, even lab to lab, there is variation, but you should say in your coding guidelines, um, base the investigative findings based on X and have a set of references you used and base your findings or your interpretation based on that set, right? And for example, if you're in the United States, you would typically use the units most commonly used in the United States labs, right? Laboratories, versus if you're in Europe, you would have a set of lab values that you use as a reference for your internal organization and the corresponding units for those labs.
Perfect. If it was reported that the patient take the treatment and experienced adverse event NOS, what can we code?
Okay, if it's reported as such, NOS means not otherwise specified, and you have very limited information. You do not have the option to get queries or clarification. Then NOS means not otherwise specified. Then you would be, you would have to use that if you can't get any additional information.
Perfect.
But you would refrain from using NOS whenever possible if there is some event listed or any other information listed, because that doesn't, for analysis purposes, NOS doesn't really help. But just to say that, well, something was reported, we can't tell what it was, then you would use that.
Great. I'm trying to see if there's any other like general ones that aren't specific. Children. Someone did just mention that they looked for an SMQ webinar, and I just wanted to put it out there that please keep checking back. We usually typically put out webinars about 2 months in advance, so we will continue to have the SMQ webinars within 2025. We will be posting those usually at the end of every month. Around the 20th is when the new webinars do get posted. So I just wanted to put that out there since someone asked that question. Otherwise, I think that's about it, unless I'm giving people a couple extra seconds to pop on. And just as a reminder, all certificates will be available within about 2 other business days. Otherwise, there are no other questions that are coming in. So those are all the questions that we've had, Samina. I think we should be complete.